Hello and good evening, everyone. Welcome to our 59th Blue Earth Virtual Seminar. Blue Earth Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Earth Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Adam Getachew. I'm the co-founder and CTO at Blue Earth Ethiopia. And we are here today with Dr. Serkalem Nurlegn. Dr. Serkalem is an internal medicine specialist, and she's here to give us a presentation on the update of heart failure management.
Thank you for the introduction. Welcome everyone to our session today. Today we'll try to focus on the new updates of management in the heart failure management. So I'll try to pass through most of the concepts in the small amount of time we have. So I guess let's get to it then. Okay. Okay, so this will be the outline of the presentation. So we'll try to do some introduction, epidemiology, and I try to classify the updates in acute heart failure management and chronic heart failure management. So as we all know, heart failure is a complex clinical syndrome, usually resulting from structural disease, sometimes due to functional impairments that results in ventricular filling abnormalities or ejection abnormalities. And usually patients present with typical symptoms with breathlessness, ankle swelling, and fatigues. And they will have specific physical signs, which I will not dwell on, as you all notice. When we try to see the epidemiology, heart failure is an important disorder because the prevalence range is 1 to 3% in the general population, which is significantly high when you compare it with other illnesses. And it's slightly male predominant disease, and 50% of the patients will have reduced ejection fraction. The incidence is expected to increase in all over the world, particularly the incidence of heart failure with preserved ejection fraction. And the outcome, despite advances in treatment, is still significant. Mortality remains high, particularly for stage 4 diseases with up to 50. So when we try to see the occurrence in Ethiopia, pooled study meta-analysis done on hospital-based studies shows the prevalence ranges from 1 to 20%. And the population who visit the hospitals are highly likely to have this disease with the occurrence of 8%, compared with the general hope, which is considered to be 2%. The other different issues in our setups are the cardiovascular disease, the heart failure, because the rheumatic valvular heart disease intends in younger patients, but it's an evolving demographics with increasing heart failure with preserved ejection fraction in towns that's occurring in older, traditionally cardiovascular high-risk patients. So I'll try to focus, these are the summary of the most important trials that were done on cardiovascular and heart failure management. I'll try to focus on the studies since 2014, since they have the most relevance. So there are so many ways to classify heart failure, but I'll try to use the structural classification because it pertains more to how we apply treatments. So we all know we have the reduced ejection fraction, which is based on 40% ejection fraction of the left ventricle, mildly reduced heart failure, ejection fraction, which is 41 to 49, and heart failure with preserved ejection fraction, which is greater than 50%. And there's a new class of heart failure with improved ejection fraction, which are patients who were previously having an ejection fraction of less than 40%, who have an increase with greater than 10 points from the baseline, or if they get to develop ejection fraction of 40% with GDMT or other managements. So first, we'll try to see the acute heart failure management. So the new onset or recurrence of symptoms and signs of heart failure, and that requires urgent or emergent therapy and resulting in hospital admission or unscheduled visit to the hospital is classified as acute heart failure. So we all know the pathophysiology, but just to summarize, a substrate or occurrence of a normal or structural heart disease or patients who are having chronic heart failure will be triggered to develop, heart failures due to different conditions: hypertension, acute coronary syndrome, arrhythmia, infection, or it might be drug non-adherence. In our setup, Studies show 60% of heart failure patients are new diagnosis patients, which means they're presenting for the first time with heart failure requiring hospital admission. But in other setups, the most important triggers are cardiovascular disease, like ischemic heart disease, arrhythmia, and drug non-adherence. In our setup, drug non-adherence also plays a significant importance. But since we have a lot of rheumatic heart disease patients, effective endocarditis and recurrence of rheumatic heart disease also play significant roles according to the hospital-based studies. So identifying the precipitating factors is important to prevent further recurrence and improve patient survival. So when patients present with acute heart failure, they may present with one of the four or any combinations of these clinical presentations. So they can be presenting with acute decompensated heart failure, pulmonary edema, cardiogenic shock, or isolated right ventricular failure. So this presentation will affect how we approach the patient's clinical condition. I will not bore you with the details since you already know this. So the one new thing that I wanted to discuss is patient admission. So the coach trial, which was published recently, showed that a stratified patient admission will have a benefit for primary outcome of all-cause cardiovascular mortality or hospitalization in these patients. So in this study, they stratified patients based on emergency heart failure mortality risk grade calculator, which has 11 components, which I tried to list here. So based on our setup, we can try to use the age, systolic blood pressure, heart rate, saturation, and potassium. This is easily accessible on the internet if you'd like. So based on this, the patients are classified as low, intermediate, or high risk, and the low risk patients were intended for outpatient management with close follow-up, and the intermediate and high risk patients were admitted. And in this study, it showed 12% reduction in mortality. So in a setup like ours, where resources are small and we can't admit all the patients, sometimes it's better to have stratified ways as to approach which patients to admit and which patients to treat as an outpatient basis. So we can have a clear treatment plan for the patients. So the diagnostic workup is pretty straightforward. Nothing has changed much. The only thing is the indication for cardiac biomarkers. So the BNP less than 100, ANT pro BNP less than 300, and MR pro ANP less than 120 basically rule out heart failure in reduced ejection fraction patients. But in patients with preserved ejection fraction, since the LV does not get stretched as significantly as patients with heart failure with reduced ejection fraction, the BNP, NT, proBNP, and ANP can be normal while the patients are having heart failure, which happens in 20% of the patients. So this is an important point, but these biomarkers can significantly predict patients who are in acute heart failure, despite other conditions that might increase the BNP and proBNP levels. So the most important thing when we admit these patients in acute heart failure is the decongestion strategy. So we always should monitor the patient's fluid intake and measure their weight daily, assess for clinical signs of congestion and hypoperfusion. So we have a class 1 indication for loop diuretics as a decongestion therapy. We all know that we should try to double the doses based on the treatment response. And if that's not working, we can try sequential nephron blockage using thiazides. And additional use of spironolactone has additional benefits, which we'll discuss later on. And if perfusion cannot be provided for adequate diuresis, low dose of dopamine use can increase renal perfusion and make the delivery of loop diuretics more effective, resulting in better decongestion. Other is IV nitroglycerin as a decongestant can be used, especially in patients who are having acute pulmonary edema. As an alternative, nitroprusside also might be used as an adjunct to diuretics, especially if there is significant dyspnea and resistant pulmonary edema, which can only be used in the absence of hypotension because they are both vasodilators and result in severe hypotension. So this is the basic way in which we titrate the loop diuretics. So generally, if a patient was already on oral loop diuretic, we start with double the dose of the oral dose. If not, we start with optimal 40 milligram IV Lasix, which are shown benefit in all of the studies with producing adequate urination. So we don't do urinary spot sodium here, so we can use the urine output, and 100 to 150 ml per hour production shows that we're having adequate diuresis. So we can try repeating similar dose every 12 hours, or if that's not responsive, we can try to double the dose. If that's not still working, we can use combination diuretic therapies. So the most widely used ones are the spironolactone and the HCT. So what's new here is the ADVOR trial. The ADVOR trial used acetazolamide as an adjunct diuretic in acute heart failure. So in these patients, they used 500 milligram of acetazolamide to increase the ease of diuresis and decrease congestion within 3 days of the patients presenting with acute decompensated heart failure. So the study shows successful decongestion occurred in 42.2% of the acetazolamide group compared to 30.5% of the control group, which showed addition of the acetazolamide therapy was beneficial, but the issue with this study was most of the patients in which we would need an additional diuretic have been excluded from the study based on the exclusion criteria. So patients with hypotension, patients who are requiring IV diuretic Lasix equivalent dose of 80 or more have been excluded from the study. So the benefit of acetazolamide in patients who are requiring a very high dose of Lasix cannot still be ascertained, but patients who have a very good blood pressure and requiring low dose of furosemide can benefit from the addition of acetazolamide based on these results. The recommendation on the guidelines requires more studies to be done to recommend as a class 1 or 2 recommendation. The other one is the evidence for Sarcopteryl valsartan. So the most important thing with acute heart failure is the mortality rate within the first months of hospital discharge is very high. So our goal is targeted towards decreasing this first month mortality. And one of the drugs which has shown significant benefit in reduction of the mortality in the first 1 month of hospital admission is Sarcopteryl valsartan, which is an ARNI drug. So there are different studies. The first one is the pioneer heart failure, then transitioning the paradigm shift studies. So the first studies showed only NT-proBNP reduction. The second study showed 20% risk of cumulative deaths from cardiac disease and 21% reduction of heart failure hospitalization and 16% reduction of risk of all-cause mortality, which is a very significant number. So I'd like to significantly stress if the patients can afford it and the drug is available, it's very important to start the patients on the Sarcopteryl valsartan while treating them for the acute decompensated heart failure to decrease early hospitalization, early hospital readmission, and all-cause cardiovascular mortality, especially within the first 1 month. The other one is the IMPULSE study. So this study evaluated use of empagliflozin in acute heart failure patients despite their diabetes status. So the primary outcome in the study was composed of days, number of heart failure events, and time to first heart failure event after discharge, and change in Kansas cardiomyopathy questionnaire symptom score. So the secondary outcomes were days, heart failure events, acute renal failure, and change in KCCQ. So empagliflozin was associated with significant clinical benefit at 90 days in patients with acute decompensated heart failure, and it was associated with fewer doses and improvement in quality of life. So there were no safety concerns that were different from the control groups. So this is also another study showing early use of empagliflozin, particularly in patients who already have diabetes, will have a dual benefit and decrease the early readmission, early heart failure events, and cumulative deaths. As you can see from the numbers here, it's a significant 4.2 versus 8.3, and heart failure events 10.6 for 14.7. So these are some in addition to the optimized GDMT therapies, which include diuretics, the decongestion, the addition of ARNIs, ACI inhibitors, addition of optimized GDMT include targeting specific conditions. Okay, so patients with heart failure and hypertension require optimal GDMT therapy. Patients with heart failure and type 2 diabetes require SGLT2 inhibitor drugs with proven benefits like empagliflozin, dapagliflozin, and to some extent canagliflozin, especially in heart failure with reduced ejection fraction. In patients with left ventricle less than 35 and resectable coronary anatomy for cardiac revascularization, we need surgical or PCI interventions. Valvular artery disease or cancer therapy requires multidisciplinary management, which is most of our patients. So preventing recurrence in these patients requires adjustment of valvular diseases, like either transcatheter valvular interventions or valve replacement therapies. Select patients with heart failure and atrial fibrillation is associated with a significant risk of recurrence and very high risk of stroke and arrhythmia, recurrent arrhythmia. So these patients, even though we can't use the CHA2DS2 score for patients who have arrhythmia secondary to severe mitral stenosis, for all the other patients, CHA2DS2 score can be used to start anticoagulation, and we should have a low threshold for this patient to start anticoagulation. The other one is IV iron replacement therapy. So iron deficiency is associated with recurrent admission and low quality of life. So transfusion in these patients. The other one is rhythm control strategy. So most of the studies have shown that even in end-stage heart failure patients requiring cardiac transplants, decreasing the risk of arrhythmia, AV nodal ablation, and treatments, CRT implantation, has shown morbidity and mortality benefits. So it has a great way recommendation, even though it's based on very small studies. Obstructive sleep apnea is another issue which is usually forgotten. So these patients are very highly likely to develop right-sided heart failure, and management of the obstructive sleep apnea with home CPAP therapy is very essential to prevent treatment recurrence and disease progression. The other one is a new class of patients which are presenting now because we are managing to save cancer patients. So cancer therapy-related cardiomyopathy should be strongly addressed with recommended therapies like RBCIs and beta blockers, and it has shown some benefit with improvement of left ventricular ejection fraction with these standard treatments. So this is what I've tried to already discuss. The other important issue here is in patients with, this is the other new thing. So Findranon, there are two different studies conducted in type 2 lame patients with CKD and heart failure, and in these patients groups, it has shown significant benefits with decreasing heart failure mortality, disease progression, CKD progression, and cardiovascular mortality. So if the patients have additional comorbidities of type 2D and CKD, Findranon is recommended to reduce the risk of heart failure or hospitalization. So the most important thing is how we discharge the patients. Okay, so in our setup, most of our patients will be decongested. They will most likely be put on persistent diuretic therapy without the addition of the GDMT, mostly because of low blood pressure. So there are two ways to starting the baseline important for drugs in these patient groups. So all of our patients ideally should be put on ACE or ARBs, beta blockers, mineral receptor antagonists, and SGLT2 inhibitors. So how should we start? If the patients have low blood pressure and we don't trust them to tolerate all of the medications at once, the conventional stepwise approach is preferred. So all of the guidelines say ACI inhibitor or ARBs, but they're not equivalent. ACI inhibitors have shown significantly better benefit in diabetic patients, in cardiovascular disease, in heart failure patients than the ARB patients. So our preference should be for ACI inhibitors unless we have contraindications. So after starting that, we can start the beta blockers and then the mineralocorticoid agents. But according to the new findings, if the patients can afford ARNIs before the Rs, we can try the RNs first. And then at the end of it, we can start the SGLT2 inhibitors. So this can all be done within 2 weeks, but reaching full dose in complete titration might require up to 6 months if we use a traditional setting. So this is the problem with this conventional sequencing. And when we try this, we pass that critical time of the first 1 month without reaching the therapeutic necessary dose for wide outcome prevention. So they have done this strong heart failure trial, which tried rapid sequencing. So the most beneficial drug for the patients are, according to previous studies, beta blockers and MRS decrease the highest risk, and now the SGLT2 inhibitors. So they tried starting beta blockers and SGLT2 inhibitors in select patients who have a blood pressure of greater than systolic one, greater than 110. And then they added the RNAs and finally the mineralocorticoid receptors. And in these patients, it has shown significant benefit with decreasing early heart failure admission and all-cause cardiovascular events. So if your patients can tolerate it, you can try dual therapy first and try to escalate accordingly. And the other important issue is when we discharge the patients, an intensive strategy of initiation and rapid up titration should be in place in the patients after discharge should be seen as early as possible, with the initial visits with being in the first 2 weeks and multiple visits within the first 6 weeks. And we should try to up titrate the drugs as fast as possible to the target doses, which are doses which have shown significant benefit with decreasing the cardiovascular disease progression or mortality. So what are the prognostic factors? So systolic blood pressure less than 120 is associated with 7.2% in hospital mortality and 14% 2 to 3 months mortality overall. So hypotensive patients at discharge are highly likely to die. The other one is blood urea nitrogen greater than 7 milligram per deciliter. Other factors of concern with less impact on the mortality but still significant are hyponatremia, elevated creatinine, advanced stage dyspnea, and congestion despite diuresis. All of these patients with these risk factors are highly likely to get readmitted and very likely to die from heart failure mortality. So since we've seen the acute heart failure management, now we proceed to the chronic heart failure. So we all know how the structural heart disease progresses. So despite our treatment methods, we have significant case fatality rates. Okay, so as you can see from here, based on the NIHA class 1 year mortality is very high for class 4 symptoms with 25 to 60% and only 5 to 10% 1 year mortality. So you can see here from the graph, as the years go by, the mortality still increases significantly. So that's why we should at best try to prevent the occurrence of heart failure and then prevent recurrence of hospital admission requiring disease. So absolute mortality rate, that I've said repeatedly, is 50% within 5 years of diagnosis. So the other important issue is although heart failure with preserved ejection fraction is increasing in prevalence, is this conception that it has some somewhat better prognosis than heart failure with reduced ejection fraction, but it is not to be ignored. So you can see here from the graph there is significant all-cause mortality. So I'm going to mention the general measures that should be done in patients with heart failure with preserved ejection fraction because we have good drugs and good treatments for heart failure with reduced ejection fraction that have shown significant benefit, but heart failure with preserved ejection fraction is still a very diverse group of patients with different etiologies and progressions, and most of the treatment is based on managing additional risk factors rather than the heart failure itself. So we'll also try to see some of the general measures. So treatment of comorbidities takes significant precedence in patients with chronic heart failure, and we should, as I said earlier, treat the precipitants, stop smoking, limit alcohol intake up to 3 glasses for male and 2 glasses per female, immunization for influenza and pneumococcal disease, especially with age greater than 65, recurrent heart failure, and immunocompromised patients. Other essential thing is we should try to always see the drugs that the patients are on. So NSAIDs are very detrimental drugs for patients with heart failure, and chronic use of those will result in RAS system abnormalities resulting in AKI, fluid retention, and sometimes flat-out heart failure precipitation. Anti-arrhythmic drugs, except amiodarone and dorfilitide, have been shown to cause cardiovascular suppression, resulting in heart failure. So, if the patients are not on these anti-arrhythmic agents, we should try to switch as much as possible. Idolidones are known to cause cardiomyopathy, so as much as possible, they should be avoided in patients with risk of heart failure and definitely be avoided in patients already established heart failure. So calcium channel blockers, the best safety data is available only for amlodipine. So if we have to use, it's preferred to use amlodipine. Antidepressants, except SSRIs, are non-precipitants, chemotherapeutic drugs. The other one is sildenafil. So use of sildenafil, except in patients with pulmonary hypertension associated with pulmonary arterial disease, is not recommended in the patients because it causes hypertension. Systemic corticosteroids might be associated with edema and fluid retention, resulting in exacerbation of heart failure. So as much as possible, we should try to keep the patients on inhaled corticosteroid therapy and prevent systemic corticosteroids as much as possible, or at least try to keep them as the lowest dose as possible. Dietary sodium restriction, 2 to 3 grams daily, is recommended for all patients with heart failure. And most importantly, reduction by half of the daily consumption of sodium has shown significant benefit. Further restriction is required in patients with severe heart failure, but it has not shown benefit in the general group for patients with stage 1 or stage 2 diseases. So fluid restriction is indicated in patients who have hyponatremia or congestion. Weight control is important. So we should try to teach the patients to measure their weight frequently, and weight gain of 2 to 3 kgs over 72 hours should be considered as a sign of heart failure because it's a sign of congestion. The other essential things that should be included in their lifestyle is exercise. So 20 to 30 minutes of walking 3 to 5 times per week is recommended for these patients. It reduced symptoms, it increased quality of life, exercise tolerance. So it's highly recommended in these patients. The only situations in which it's contraindicated is major cardiovascular events in the preceding 6 weeks, major procedures, preventing activities, significant arrhythmia, or exercise intolerance on cardiovascular testing, exercise testing. So the workup is pretty straightforward. So these are the important steps that we should follow in managing these patients. So as I've said earlier, heart failure with reduced ejection fraction has basic 4 group of drugs that are used to improve disease progression and even improve left ventricular ejection fraction. So ACIs and ARBs and ARNI are classified in the same group because they provide the same benefit. Beta blockers, MRAs, and now SGLT2 is also included in this group because it has shown significant benefit. All of the dapagliflozin, empagliflozin, and canagliflozin have shown significant benefit in heart failure with reduced ejection fraction. They've decreased disease progression, hospital admission, and all-cause cardiovascular morbidities. So all of this should be included. Diuretics are used as needed in patients to address congestion. So despite the use of these basic DDMTs, if the patients have persistent heart failure symptoms, then there comes hydrolyzing isosorbate nitrate. So this is an important drug, particularly in our setup, because it has shown significant benefit in African American patients. So the guideline recommendation is for patients who are not responding to initial treatments with above listed medications, especially for congestion. in dyspnea, it has shown significant benefit. So even if the hydralazine ascorbyl dinitrate is not available, we can try to use both drugs together with nitrates and hydralazine combined and together. The other one is in patients with left ventricular ejection fraction less than 35% and greater than 1 year survival, and intracardiac defibrillator is important to prevent sudden death. So it's a class 1 recommendation. We'll try to see the evidences later on. The other one is if the QRS is greater than 150 milliseconds with LVB, it means there is desynchronization of the ventricular contraction. So in this patient, CRT implantation has shown significant benefit and it has a class 1 recommendation as well. So if despite doing all of this, the patients have refractory heart failure, then we proceed to palliative care cardiac transplant or mechanical cardiac aids like LVAD implantation. So first, I would just try to assess the diuretics. So potentially all patients with symptoms and signs of congestion deserve diuretics despite the left ventricular ejection fraction. Usually it's more required in heart failure with reduced ejection fraction. So thiazide diuretics can be used as an additional agent in patients with preserved renal function. Okay, so these agents are known to cause worsening of renal ejection GFR, and they are also known to cause hypokalemia. So if we add hydrochlorothiazide or other thiazide diuretics to the loop diuretics, we should strongly follow these patients' creatinine electrolytes. So the risks are pretty straightforward: significant hypokalemia, significant renal dysfunction, hypotension are the risks. And the other important things with the addition of SGLT2 inhibitors, they also have their own diuretic effects. So if we combine these drugs with SGLT2 inhibitors, we should be cautious because the patients might end up being severely dehydrated and might result in electrolyte imbalance, and in some cases might even precipitate diabetic ketoacidosis. So should we try to see the dose, try to see the urine output and electrolytes as frequently as possible when we add the diuretics to SGLT2 inhibitors. So furosemide, metadine, and torsemide are the most usual diuretics. So the important thing here is, so furosemide has like 40 to 70% bioavailability, but metadine and torsemide has upwards of 80% bioavailability. So in patients with right-sided heart failure and resistant diuretic resistance, it's preferred to use bumetidine and torsemide if they're available, although they may not be so in our setup. So metolazone and hydrochlorothiazide are also the preferred thiazide like diuretics. Other non-thiazide like diuretic, which has shown significant benefit and also used well in hypertensive patients, is indapamide. So we can use these drugs with in combination. So as I've said earlier, ABCI is recommended for all patients with heart failure, reduced ejection fraction, beta blocker, MRAs, dapagliflozin, and empagliflozin, and sacubitril valsartan are recommended. So sacubitril valsartan, after this guideline recommendation, has been updated to class A. So these are the different studies that were conducted to prevent heart failure events in at-risk adults with type 2 diabetes. So all of these studies show significant risk reduction in these patients, which resulted in their recommendation. So eftoglufasin study was done only in type 2 DIM patients. It has not shown benefit in non-type 2 DIM patients. So all of these studies are initially conducted on type 2 DIM patients. Since it has shown significant benefit, the study was done on patients without type 2 diabetes, and it has still shown significant benefit, which has led to its recommendation as an independent heart failure medication for empagliflozin and dapagliflozin. So this is more of the same. The important thing here is the ivabradine. So ivabradine should be considered in symptomatic patients with heart rate greater than 70, despite maximal tolerated dose of beta blockers. So ivabradine is a funny current channel inhibitor. 5 milligram for BID has shown significant benefit in decreasing the risk of heart failure hospitalization and cardiovascular deaths. The hydrolyzing method is something, as I've said earlier. The other drug which is widely available in our setup in used is digoxin. So digoxin has no place in patients with heart failure with preserved ejection fraction, which is something I really like to stress out. But in patients with reduced ejection fraction, it may be considered sometimes, especially in patients with hypertension and symptomatic heart failure. So it decreases heart failure admission, but it doesn't have significant benefit on mortality, as we try to see later on. And it's not a first-line recommendation. The recommendation is class 2B. So these are the drugs that have study-proven benefits on heart failure. So captopril, narapril, lisinopril, ramipril, and amitriptyl. So these are the starting doses, and these are the target doses. So as much as possible, we should try to reach to the target doses to get the maximal benefit from the drugs in these patients. Bisoprolol, carbidopa, and metoprolol, since in extended release, are the drugs which are preferred. Nebivolol is preferred in patients with aortic pathology and in older patients with significant benefit. So these are additional agents which we'll try to see later on, like vericaguat. So since I've already mentioned about the hydrolyzing study, so initially the VHIFT trial showed that it has significant decongestionability, as you can see here on the picture, and it has decreased mortality in patients who are already on maximal tolerated dose of ACI inhibitors and beta blockers and spironolactone. It has shown significant benefit. So the study was again repeated on patients who predominantly identified themselves as Black, and in those patients it has shown even more benefit. So the study concluded that the study can be interpreted to be for hydrolyzing to be useful in all Black patients. So if the patients do not have the intended outcome from the original treatments, hydrolyzing method can be added to their treatment. This is the shift trial for the EVA regime. So as I've already mentioned earlier, the recommendation is for patients with age greater than less than 75, we are averaging 5 milligram per BID. If their age is greater than 75, we use 2.5 milligram BID. The goal is to reduce the heart rate to 50 to 60. So we continue the 5 milligram BID in this case. If it's greater than 60, we may increase it to 7.5. And if it's less than 50, we have to reduce it back to 2.5. And in patients with history of prior arrhythmia, the starting and continuation dose is 2.5 milligram BID. So its recommendation is for patients who are already on maximally tolerated beta blocker therapy. So the contraindications, as I've said earlier, is heart failure with preserved ejection fraction, presence of angina, hypersensitivity, and conduction abnormalities like 6-sinus syndrome, ASINO, surgically block, and resting heart rate, which is less than 60. So since we usually use digoxin, I thought we might also review this initial studies that were done in 1993 and 1997, the Radiant synthetic trial. So as you can see here, so this study is the DIG trial, which has shown that there is no benefit in overall mortality with the digoxin, but the Radiant trial here showed that the patients, when the digoxin was withdrawn, the patients became symptomatic. As you can see, the event rate increased. So the persistence of the digoxin showed decreased heart failure admission, and the withdrawal of the attempt of the digoxin withdrawal resulted in more symptom in these patients. And the other important thing is, even though we're not able to do it here, the serum digoxin level should be below 0.1. Any level greater than that is associated with significant morbidity and mortality and no significant benefit. And the other important issue is in patients with significantly reduced ejection fraction who are not tachycardic, there is no need to load the patient when starting the digoxin dose. we can just start them with the half dose. So the other important thing is the adjunctive pharmacological therapy. So as I've already mentioned, anticoagulation is a significant issue. So in patients with atrial fibrillation or left ventricular thrombus or prior history of thromboembolic event, this should be strongly considered. And I'd like to significantly state that antiplatelets are not equivalent to anticoagulations. Okay, so aspirin does not necessarily prevent patients from developing strokes or arrhythmia-related strokes or any thrombus-related events. Okay, the only place to use aspirin is in patients with charged vascular score doesn't qualify for anticoagulation or in patients who have significant Hasbled score in which starting anticoagulation would result in significant bleeding as compared with the benefit to be derived from the starting of anticoagulation. So management of arrhythmias is important. So correction of electrolyte and acid-base disturbances is also important. ICD is something that I've already mentioned earlier. The cardiac resynchronization therapy. So as I've said earlier, most patients, especially the ones with reduced ejection fraction, when the cardiac muscle becomes significantly stretched and dilated and scarred, it starts to develop abnormal conduction systems, and it ends up having abnormal interventricular or interventricular conduction system, which causes desynchronous ventricular contraction, which contributes to significant recurrence of heart failure symptoms. So this manifests as QR restoration of 120 milliseconds and LVB pattern on the ECG. It's more visible when the QR restoration is greater than 150 milliseconds. So cardiac resynchronization therapy, what it basically does is it stimulates both ventricles simultaneously, which improves the cardiac contraction and coordination of the ventricular contraction, reducing the severity of mitral regurgitation and heart failure symptoms. The interesting group here is heart failure with mildly reduced ejection fraction. So these are patients who are midway between reduced ejection fraction and preserved ejection fraction. So most of the patients in the lower end of the spectrum behave more like patients with reduced ejection fraction. Patients on the higher end of the spectrum for ambulatory behave more like heart failures with preserved ejection fraction. So I mentioned this group because use of treatments that are indicated for reduced ejection fraction has shown benefit in the mildly reduced ejection fraction patients, and they should be used. The other group is heart failure with preserved ejection fraction. So this is a group up until 3 years ago did not have any significant drugs with important benefits. So the only drugs that have shown some mild benefit previously were the spironolactone topcat study. The other drugs had not shown any significant benefit previously. Perindopril has some benefit, but it was not statistically significant, as you can see here with the p-value. But things changed drastically over the past 3 years, and we have breakthrough data from the SGLT2 inhibitor. So empagliflozin outcome trial with infrared preserved and dapagliflozin trial with preserved heart failure and the deliver trials have all shown significant benefit of SGLT2 inhibitors in this group of patients with decreasing reduced heart failure outcomes and cardiovascular outcomes as well. So now we have a strong contender that we can use in these patients to decrease recurrent heart failure. In some patients, with heart failure with preserved ejection fraction, MRA, which is spironolactone, and ROC and RNAs may be considered to decrease hospitalization, particularly when they are on the lower end of the spectrum and their use is given class 2B recommendation on the guidelines. So the other issue that I would like to mention is the treatment withdrawal. So most of the time patients don't want to take multiple medications, and they want to be weaned of the medication. So there were different studies that were done, especially in patients with heart failure with reduced ejection fraction. And one of the studies attempted to reduce the withdraw the medications after 3 months of optimization. So most of the patients had a recurrence of heart failure symptoms in less than 3 months after the discontinuation of the treatment. So that study suggested it was not optimal to try to wean the patients before the ejection fraction has improved. So again, the trade heart failure study tried to do the same thing, but after the patients have recovered their ejection fraction. So these are the patients which this has been tried on are the patients which I've mentioned earlier, the new group of patients with heart failure with improved ejection fraction. So most of the patients had GMT therapy and their ejection fraction had improved from baseline. So treatment withdrawal was attempted, but almost all of the patients developed the recurrence of the heart failure symptoms and their ejection fraction dropped. So the conclusion was many patients who are deemed to have recovered from dilated cardiomyopathy, they will relapse following treatment withdrawal, and unless robust predictors are available, treatment should be continued indefinitely, and we should not try to discontinue the treatment from these patient groups. The other important thing that I wanted to mention here is the treatment in special populations, particularly in pregnant patients. So pre-pregnancy counseling and optimization of therapy is of utmost importance in these patients, and preferably treatment should be optimized before pregnancy is attempted. Any structural lesions should be addressed, and anticoagulation requiring conditions should be avoided. Arrhythmia management should be optimized, and if possible, arrhythmia ablation should be conducted. So, despite that, if acute heart failure occurs while the patient is pregnant, there is a benefit for using BNP as initial stratification. So, a very high level of BNP is associated with a worse prognosis and intensive treatment requirement. For BNP doesn't have much use in pregnancy. So, as a diuretic, we can use loop diuretics. Patients who are already on beta blockers for treatment should continue them throughout the pregnancy. For patients with congestion in pulmonary edema, hydralazine and nitrate has significant benefit in improving the dyspnea and improving the pulmonary edema. Nitroglycerin can also be used in these patients. So the other important thing I wanted to mention is when we use inotropes, dopamine is the preferred agent in pregnant patients because unlike noradrenaline and adrenaline, it has a less risk of impairing uterine blood flow and neonatal perfusion. So as much as possible, dopamine should be used, but in conditions in which establishing blood flow and preventing shock is more important than the pregnancy. In those cases, both noradrenaline and adrenaline can be added to the treatment. Digoxin can also be used in pregnant patients, although it's not preferred, especially if it's used for rhythm control and increasing cardiac output. It can be continued throughout the pregnancy. So, as we all know, ACI, ARBs, and ARNIs are known to be teratogenic, and they should be avoided. MRA should be avoided. Nitroprusside should only be used as a last resort in these populations. So this was my presentation so far. So if you have, these were my references. If you have any questions, please put them in the chat box. Okay, so I see here the place of statin for heart failure, which is an important question. So the place of statin for heart failure is in terms of ischemic heart disease. So in patients who have developed ischemic heart disease, the recommendation for statin use is for lifetime. So in those patients, the statin doesn't particularly per se prevent the heart failure, but it prevents the occurrence and progression of the ischemic heart disease, which in turn prevents the occurrence of the heart failure. So in patients who develop ischemic heart disease, statin is indicated. It's a class 1A recommendation, and it's recommended to be taken for a lifetime. The other is sacubitril/valsartan available in our country? Yes, it's available. It's available in the Ernesto form, which is provided by the Novartis, and there are some generic forms which are available as well. And what we've learned so far is if we prescribe the medications, the pharmacists will find a way to bring the drugs to the patients. The only issue is the cost is a little bit expensive, so our patients may not afford it. But if your patients can afford it, please use all the drugs, all the medications that I've mentioned, even the Vericabot is available. So if your patients have the money and the access, you can use it. Do not limit yourself to the economic situation of most of our patients. So the place of Vericabot is in patients who have already put on all of the JDMT drugs that I've already mentioned and still have symptomatic heart failure. Vericabot can be added to the treatment, especially if they have arrhythmia or reduced ejection fraction. Okay, any other questions? Okay, beta blockers have no significant benefit in patients with heart failure with preserved ejection fraction. As I have said earlier, the only drugs which have significant benefit in heart failure with preserved ejection fraction are the SGLT2 inhibitors. The other drug with proven benefit is spironolactone, but we can try beta blockers and ACI inhibitors only in patients who have specific indications, like for example, if the patients have associated CKD or if the patients have diabetes, or beta blockers if they have like tachycardia or symptomatic symptomatic associated hypertension. We can also use the beta blockers, but based on their benefits, beta blockers and ACI inhibitors do not have a direct indication for heart failure with preserved ejection fraction. Beta blockers in patients with valvular heart disease without atrial fibrillation. Okay, this valvular heart disease, it depends on which type of valvular heart disease they have. Okay, so for example, in patients with aortic stenosis, it's not recommended to use beta blockers because it will result in reduced ejection fraction and symptomatic precipitation. But in patients with, for example, MR, you can use beta blockers. But in some case of atrial stenosis, in some case of mitral stenosis, beta blockers are even contraindicated. So valvular heart disease is a separate topic, which requires its own drug modifications, and this depends on the hemodynamic outflow of the patient. So if their patient is only using the tachycardia to produce adequate cardiac output, use of the beta blockers will precipitate severe heart failure and is not recommended. So atrial fibrillation management in valvular heart disease associated disease is also different. So we do not recommend use of beta blockers for atrial fibrillation management associated with severe MS. We have better drugs for it, like amiodarone, and sometimes even digoxin, but we don't prefer beta blockers for these patients. Non-valvular disease associated atrial fibrillation can be treated with beta blockers. Okay. Acetazolamide for decongestion as a single agent, it's not recommended at all. As a dual agent with Lasix, it can be used, but as you have seen the study, acetazolamide was used only in patients who required Lasix, which is less than 80 milligram per day. So that's very unrealistic in our setup, okay? So at least we use Lasix 40 milligram IV BID for the patients per day. If the patient is requiring less than that, we basically don't have a problem with decongesting them. So there's no need to add in the acetazolamide. But it can be tried in patients as an experimental therapy when they don't produce enough urine output, but it's easier to escalate the dose of the Lasix rather than using the acetazolamide while using a very low dose of Lasix. But for an outpatient patients in which you don't want to use hydrochlorothiazide and feel safer with a low dose of Lasix, acetazolamide is useful. They also used acetazolamide pure IV was not used. Acetazolamide is used as a PO therapy as well. Spironolactone has a significant benefit for heart failure with reduced ejection fraction. There are multiple studies for prolonging spironolactone, so it is recommended for all patients with heart failure with reduced ejection fraction. Okay. So with SGLT2 drugs, for type 2 diabetic patients with heart failure, canagliflozin, dapagliflozin, and empagliflozin have shown benefit. But for patients with only heart failure without having type 2 diabetes, empagliflozin and dapagliflozin are the ones where we have significant, robust data. So our preference is towards empagliflozin and dapagliflozin. Ertugliflozin has shown some benefit in patients with heart failure and type 2 DIM, but no benefit in isolated heart failure patients. And canagliflozin study is not concluded in heart failure with reserved ejection fraction.
Those are all the questions.
Okay, so I think we finished the questions. Okay, diuretics. Okay, diuretics in CHF and shock. Okay, so the most important thing while the patient is congested and also in shock is establishing the perfusion towards the tissue. So dopamine and noradrenaline should be your first priority, and diuretics can only be used after you established perfusion. Without producing adequate perfusion in detectable blood pressure circulation, the diuretics will not be delivered towards the kidney, and in that case, you will not be able to diurese the patient. So if the patient presents with cardiogenic shock, you cannot diurese the patient without getting him out of the shock first. So the first step should be targeted towards getting the patient out of shock with vasopressors and inotropic agents. And then you can try the diuretics. So Lasix is still preferred in those patients, and since giving a bolus dose is not recommended, those are the patients in which Lasix infusion with low dose can be tried, while also trying to maintain the peripheral perfusion using the vasopressors.
All right. Thank you so much, Dr. Serkalem, for taking your time to give us this amazing presentation. And hopefully in the future, maybe we can re-invite you here with another tech setup or in another topic. I'm looking forward to that. And thank you so much, Doctor.
Thank you so much for attending. Have a nice night, everyone.
All right. Good night, Doctor.
Good night.